Welcome everyone to this educational program on integrating psychosocial supportive care into the clinical management of short bowel syndrome or SBS. This is part 2, providing psychosocial support to patients with SBS and family members. We're really looking forward to this exciting presentation. We've got a panel of faculty who you will be hearing from in just a few moments. And the objectives of this program, so this is part 2, it's a continuation, and for those who might have missed part 1, you can access the recording on the AKHCME website. But our objectives today are to continue the discussion around the unique psychosocial needs among patients with SBS and their family members, explore the reasons why they are at high risk of developing significant psychosocial distress, explain some of the reasons behind their distress, and identify effective strategies for managing these issues among patients as well as their family members. We're going to talk about ways to coordinate care as well as employ team-based care coordination strategies. So with that in mind, our first presenter is Swapna Kakani, and I will let her take it away.
Thank you, Joe, and thank you for putting this on. So yes, my name is Swapna Kakani. I'm a patient and healthcare advocate. I was born with short bowel syndrome 32 years ago, and in my lifetime, I have experienced almost all aspects of the management of the disease and evolution of the advancement of the treatments of the disease. I've been on TPN and enteral nutrition my entire life. I've had 66 surgeries, including a small intestine transplant. And so because of that journey, I am going to talk about the psychosocial needs during transition. During transition, both from peds to adult, as well as from transition from local care to subspecialty care, with a special focus on oral feeding issues using my own case. Next slide, please. So to begin, I'm going to talk about transition from pediatric care to adult care. So this is a broad list of psychosocial aspects that need to be considered when transitioning to adult care, and I'm just going to touch on a couple. So one is really guiding on the acceptance of chronicity of disease, that this will be part of us for a lifetime, but how will it be part of you in that evolution of identity? And that evolves at any age, but especially during our transition years. And then really guiding on how we can own our medical care as well as our medical history, starting from a young age as we start to take independence from our caregivers, because that's going to be really important as we communicate with clinicians and navigate the adult world in the SBS IF clinicians, because it's not as centralized as it is in the peds world, and sometimes you do have to create your own pit crew of providers across the country. The other thing I want to focus on is medical trauma, and so really being aware of what some symptoms of medical trauma are and how that it can be common in the experience of a rare disease like short bowel syndrome and how to cope with it. I included this graphic because I felt like the speakers today, as well as the audience, can relate to it to some extent. As a patient, we do notice our own psychosocial needs, but it's very hard to articulate that to our medical providers. And our medical providers, they have a full-time job and more to take care of us medically, but are aware of the psychosocial needs and are trying to meet the patient in the middle. Next slide, please. So I want to focus on transitioning of care when dealing with oral feeding issues, using my own case as an example. So when I was a child, I was at the same intestinal rehab program my entire childhood, and that center managed my PN, EN, and oral feeding. They told me eat anything, really to minimize the development of oral aversion and to help foster a good relationship with food. But I also was not fed by mouth my first year of life. And I ended up eating really like a bird, eating the same meal, drinking the same drink for hours or even days at a time. And so also eating was associated with fear, pain, distension, diarrhea, nausea. I was getting tube feedings during the day and night, and TPN at night almost every single day. So when I was hungry, I was satisfied, and that was a sense of control. I felt safe, and so a lot of times I did not address my hunger, or I avoided it. And then as I got older and during my transition years, my case got more complicated. I went through a lot of surgeries, a lot of complications. I was NPO for almost 3 years of my life, which really changed my relationship with food. But it can be common to be NPO in acute periods of time after surgeries, as well as sometimes for longer periods of time due to surgery recovery or complications. And then when you're a child, the role of the caregiver has a strong presence in terms of meal planning, cooking, grocery shopping, etc. Now, as an adult, even with a small intestine transplant, I have required TPN and now enteral nutrition or tube feeding because I have not been able to maintain my own calories and hydration by mouth to sustain, because my entire life I was fed by an IV and tube and really was never accountable to eat by mouth completely. And so again, my nutrition is managed by a multidisciplinary team that specializes in intestinal failure, but not all teams really understood my etiology of not eating by mouth. A lot of teams felt that I was a functional young adult and told me, go eat, you can eat, we fixed you, just eat. And so it took time to find the team that I have today. We now have a robust education and a knowledge on what the short bowel syndrome diet is today and guidance on it. But a lot of intensive feeding programs that can help with restrictive intake and oral aversions are really focused on the ped side and rare for the adult side. And so, and when I called some eating disorder centers, and even today I had a phone conversation with one, they do not know how to treat someone with a feeding tube outpatient. And so it was with the help of a PEDS program, because not knowing where else to go and using the resources that I have to find a dietitian and a psychologist that specialize in both fields. And then today, as an adult, the role of the caregiver is very much diminished in meal planning, cooking, eating, due to age and independence. And so now I feel like as a patient and a caregiver. The diagram in the center is a summary of the different psychosocial aspects that are involved when increasing oral eating with PN and EN. Next slide, please. So this is a summary of the transition of care when oral feeding. And so there is literature, very little, on how eating difficulties and the PEDS role is not really recognized when we come to the adult side, and it can be a considerable hurdle. And we really cannot assume that someone can eat normally in adulthood when having been born with short bowel syndrome. And so what do we need to do about it? We really need to communicate with the patient as to what are their priorities. Are they willing to commit to this work? It is a lot of work, and it is a long-term process. Specialized clinicians, multidisciplinary team is needed, because it does require increased mental and physical energy, because our normal a lot of times is hooking up IVs and tubes, not planning, cooking, and feeding ourselves. We cannot assume the patient knows how to eat. Next slide, please. The next topic of transition is from local to subspecialty care. So right care at the right time at the right place is imperative, and where you live really dictates the type of care you receive. And so a lot of times adults have found that they have to find providers, home infusion companies, surgeons, GIs, etc., in different locations as to where they live. And some of that issue, it does relate to the fact that intestinal rehab programs are scattered across the U.S. and adult providers that specialize in intestinal failure are also scattered across the U.S. and community providers that know TPN management and intestinal failure are rare. But we have data on the positive outcome of intestinal rehab programs and their associated improved outcomes, consolidation of expertise, care coordination, and prevention of complications. But traveling to a subspecialty care, which is in this context is defined as an intestinal rehab program, can require a lot of time, energy, and money, and it sometimes can require really frequent visits. So coordination of care with a local provider is really inevitable and a way to sustain management of disease over time. But hospitalizations occur, ER visits, and so last year and the year before I had sepsis. And sometimes the complication like sepsis, it is not appropriate to travel the 2 hours or even 12 hours where my subspecialty care is. a heart rate of 114, fever, body aches. So you have to be hospitalized locally. You have to coordinate with the local team. Who is your local team? What is the relationship you have with your ER providers? Do they know your complicated case? Sometimes you have routine procedures. The role of the primary care provider takes a higher presence when you're an adult. Mental health provider a lot of times is local. And then a lot of times our inpatient team is different than our outpatient team, both locally and in a subspecialty care center. And so coordination of care is required. So where does that put the patient and the family? So a lot of times we are responsible for updating both teams for sustainability and consistency of care. And that's why ownership of care and medical history is so important. But that really requires guidance for the adult to take that ownership. And it is a lot of work. It takes articulation and communication skills, and it has to be done in real time. When I have sepsis, I can't wait weeks when I have time to call. I have to call right after I'm discharged. I was in the ER 10 days ago for a joint issue. I had to call the next day and send x-rays. But it does increase engagement in care, and it does increase a trust between provider and patient and our family member. But it is very hard. It is a full-time job, and it does increase avoidance, control, anger, frustration, desensitization, all these triggers that we see in the themes of psychosocial and coping mechanisms when it comes to symptoms of the short bowel syndrome. Next slide. This is an example using my own case of the process that it took to find the PIT crew that I have today. The left side is the providers that I see today, and the colors are correlated to the center that they are at, and then they also refer to the dots on the map, which you can see are not at the same location. And then the blue arrows and the yellow dots refer to the centers that we traveled to when I was having complications all during my transition years in order to find the right care at the right time at the right place. Next slide, please. And then lastly is our resources. These are not resources that are catered to transition, because I think we have a lot of work to do in that area in intestinal failure. However, these are resources that are very supportive for the patient and are great resources for you as a provider to explore, to learn more about the disease. I purposely included hashtags because you can enter those and find accounts that articulate the disease as well as positive coping mechanisms on how to manage by myself as well as my peers. Thank you.
Thank you so much, Swapna. We're now going to hear from Dr. Jessica Allen. Dr. Allen.
Hi, thank you. Thank you for having me. And thank you so much for those of you that are logged on and really taking an interest in this really important topic. My overarching kind of message today is that I want you to hopefully take away a couple of things. One, that psychosocial needs of individuals with short bowel syndrome and those in their life who are touched by short bowel syndrome are not static, and that they may change, and they especially might change during periods of transition. And I'm hoping that we'll kind of think creatively about what transition means. That there are sensitive periods of transition, and the players involved might be the place, but also providers and caregivers and siblings. And so I want to talk about those folks. And then I also want to say that I hope that you take away from this kind of brief talk that individuals with short bowel syndrome do not experience psychosocial distress or psychosocial well-being in isolation. It's very much a reciprocal relationship between the person with short bowel syndrome, their providers, and their caregivers as well. So looking forward to talking with you about that today. Next slide, please. So why I study this in the first place, I'm actually a person who specializes in geropsychology originally, but I am now the parent of this beautiful little honey here. She's older than this now, but who has short bowel syndrome. So my background is in caregiving and quality of life research, but mainly for a community of aging folks with chronic illness. So I study, I have an invested interest in short bowel syndrome and kind of talking about family-centered care and psychosocial needs and that population now. So just to give you a little bit of history about her case, because it's important to me and drives a lot of my work. I wanted to tell you a little bit about Charlie here. So Charlie was born at 26 weeks and 2 days. She was about 2 pounds, 3 ounces when she was born. And about 4 weeks old, had necrotizing enterocolitis, had a resection, and then continued to be necrotic and had a second resection, or revision, I should say, following that. So we actually have a fair amount of bowel in the short bowel world. We've got about 65 centimeters in continuity, most of the colon. But she was previously TPN dependent and has a G tube. Much like many individuals who either have short bowel from birth or later acquire short bowel, even to adulthood, she has other diagnoses. And so as we talk about the psychosocial needs today, I hope that one thing that you carry with you is that we are, like Swapna just said, trying to navigate multiple teams who have multiple and sometimes even competing goals with one another, and how that can even add to psychosocial distress. I have the picture here of her older sibling getting in on the bolus feed there, just to show the team approach. Next slide. So one of the primary transitions when I first kind of started noticing some of the gaps, I would say, in psychosocial support was during our NICU experience. And I recognize not everyone has a NICU experience with short bowel, but that is ours. We actually had 2 hospitals. The hospital on the left, the one that's labeled as Hospital A, that was where Charlie was born, and she had her first 2 surgeries. It was a large regional hospital. It was the only level 3 NICU in the general area at all. And while we were in that facility, we experienced a lot of periods of crisis, not so much stabilization. Having a background at Gero, I was looking at prognostic indicators and saying, we need palliative care. We need to talk about removing life-sustaining. And as you can imagine, that was a very psychologically distressing time. Unfortunately, given the resources at that hospital, they did not have but one palliative care person for peds at all. So it took several days to get in contact with those resources. And there was no kind of catch-all for where someone with family counseling needs might go to talk through some of those things. So they relied heavily on the social workers, who were not only serving in that capacity, but also trying to do things like get our insurance figured out. So if you are working in one of those kind of settings, one of the big takeaways that we found really helpful during that psychosocial distress time was that actually the Bay unit, which I know is not ideal in terms of risk of infection, it was great for peer-to-peer support. And we really made, I mean, lifelong connections with other parents who were also walking through crisis. So it essentially normalized for us our experience. We transferred later to Hospital B, and this is actually an actual picture of Children's of Alabama, which is where my kiddo spent most of her time because we live here in Birmingham. And during that time, it was more of a period of we're stabilized and this is normal. So I had gone from a Hospital A where a nurse practitioner looked me in my face and said, and I appreciated it at the time, it was hard to hear, but she used the words, "This baby will die." But we didn't have any psychosocial support. To now going to Hospital B, we're stable. We're not having those peer-to-peer supports anymore. We're not particularly what you might think of as high risk for distress. But the stabilization period was when we realized maybe we aren't normal. And we really would have benefited from some psychosocial assessment, needs assessment, and also intervention. So there was child life and some things that were available, but in essence, I think that it would be ideal if you're working with these populations to consider, am I only assessing needs during kind of what we think of as high crisis periods, but not necessarily in what might be a more stable period, which is where I think there is a whole cohort of patients that would and families that would really benefit. Next slide, please. So I wanted to tell you a little bit around where this theory comes from. I've got a little bit of information from a forthcoming manuscript currently in preparation of caregivers of individuals who have short bowel syndrome, patients in particular, just highlighting that when we did needs assessment and asked specifically about quality of life, we got a fair amount of feedback around mental health needs. One of the reasons why I wanted to highlight the need for psychosocial assessment during transitions to stable periods, not just crises, is around these two hypotheses that we have here in the literature. So one of the theories is the wear and tear hypothesis. And if you're familiar with Lazarus and Folkman, this is coming from their stress and coping research, that for patients and caregivers over time, their emotional well-being experiences a wear and tear process so that it becomes more challenging to cope with what may have been a minor stressor to the person. Now it becomes bigger. There's a whole competing model almost to this that's well documented in adults that actually says that a lot of people can find meaning, and it's almost a buffering effect from caregiving and experiencing psychosocial challenges, especially when those are supported. And part of that may be that when my child is having poor psychological well-being, emotional contagion might mean that I also have poor psychological well-being. Or the flip, when I am distressed, my kid may be higher distressed. So a reciprocal relationship there. But we don't think that caregiving is all bad or all good, but that the needs very, very much vary, and we need to do a better job of addressing that. Next slide, please. So one of the ways that, of course, there's so many other things I want to tell you, but one of the things that I would like to propose that we should consider when we are thinking about how do I assess psychosocial needs and when, and how do I approach psychosocial needs, is I would like to make the proposition that you consider grief. So some of the models of grief really fit well, I think, within psychosocial assessment for short bowel syndrome. So there's a whole category of grief that kind of talks about grief as having non-finite losses. So short bowel syndrome includes a number of non-finite losses. Those are losses that don't necessarily include a death. They don't include something terminal or that is going to end, but it's something that's going to continue, excuse me. So one model for thinking about grief and bereavement is the dual process model, which is one of my favorites by Strobe and Shutt. And it really kind of talks about, I don't know if you can see my hands, but I'm talking with my hands here, but you can think about it as an oscillating fan. And I think that during times of transition, we might think about some of short bowel's losses or stressors this way. So when the fan is oscillating one way, we might be focused on very loss-oriented grief-related ideologies. These are things like yearning for that which is lost, focused on what I can't do and my limitations and wanting those things. Swapna often talks about starving to eat when she couldn't, right? So loss-oriented focus. But then sometimes we shift into restoration-oriented focus. I'm going to use Swapna again as a patient because I know her and I feel like I can. She's an advocate, and she engages with OLI and other organizations in order to really advocate and engage in restoration-oriented coping. So I just want to put in your hat the idea, a little tool to think about if you're only focusing on depression and grief. I feel that you may be missing part of the story. Depression is distinct, it's related, but it's not the same thing as grief. And so considering these models, perhaps during times of transition, maybe we can catch and address some of those psychosocial needs, especially during periods of stability that sometimes we miss. Thank you.
Thank you so much, Dr. Allen. And now we're going to hear from Dr. Winkler. Dr. Winkler?
Thank you. Thank you also, Swapna and Jessica, for sharing your stories. I am a registered dietitian who has spent my entire clinical career working with adults who require parenteral nutrition in the hospital or acute care setting, as well as working with a large home parenteral nutrition program in which the majority of our patients have intestinal failure. From a research perspective, I have studied quality of life and what is the lived experience among people who live with home parenteral nutrition and intestinal failure. So I'd like to share a few issues surrounding that from both my personal work and my research. And if you can give me the next slide. Thank you. So I have conducted qualitative research, interviewing, and thematic analysis to try to better define quality of life from the perspective of the patient and to try to better understand the factors that influence quality of life. And I started this journey because the body of literature early in this field from the late 1970s, really through early 2000, has overwhelmingly reported poor quality of life in the patient population receiving home parenteral nutrition or short bowel syndrome. And in many ways, that was in conflict from what I was experiencing with the patients who I was taking care of, who reported fairly good quality of life. And I wanted to understand more of the disconnect. And I think a few of the issues relate to the use of generic health-related quality of life instruments that may not actually capture the experience of this rare chronic disease, as well as the complex technology of parenteral nutrition. And the second issue, I think, is because a lot of these tools have been designed to evaluate over time what's happening related to a drug or a therapy. And it produces a number that is compared to a control population or other like populations. And in clinical practice, it's hard to do something with that number. So I really have wanted to understand quality of life. So from this work, the overwhelming definition that emerged from this research was how much one enjoys life, being happy and satisfied with life, and being able to do what I want to do when I want to do it, which also included being able to eat what I want to eat when I want to eat it. And among the activities that were described of being what I want to do were things like going to work, doing household chores, participating in church and social activities, participating in recreational activities or playing sports, traveling, and dining in restaurants. Some of the positive influencing factors were having good health, having strength and stamina, having strong faith, having good family support, and having financial security. Among the negative influencers were gastrointestinal symptoms, which we've heard: pain, abdominal distension, diarrhea, which was described in this population as disabling, degrading, and disastrous. And I'd also include here ostomy leakage and high ostomy output. Another important theme that emerged from this work was a balance between the benefits and burdens of being connected to intravenous therapies. And what people described was being hooked up, tied down, but happy to be alive. So there was a way to begin to accept it and emphasize the benefit versus the burden. Issues around training and educational preparedness really do influence a person's quality of life. And a lot of people felt like they were not fully prepared to undertake the experience of doing parenteral nutrition therapy at home. And that when they left a large academic medical center and traveled hundreds of miles back home, and even when they were in close proximity to academic medical centers, they didn't always find experienced or familiar healthcare personnel or home care personnel, clinicians who could assist them. And that was overwhelming and really a difficult scenario. And then a lot of theme around, as we heard just now, achieving normalcy in life, really establishing a new normal. And what assisted in this was coming to the acceptance of the disease state or having the therapy of TPN, recognizing that life is different than it was before, but really having the ability to carry on and using a lot of things like comparison or downward social comparison and things to help with this. And next, understanding that while life was different, it's better than the alternative. Just being alive and waking up every day was a really good thing, and people talked about this. And I'd add one additional factor here, and that was finding others just like themselves. And many times people had to do that on their own through a Google search. And so I think Swapna's list of the resources that are available are really important. And it's important for us as clinicians to introduce our patients and clients to these resources. OLI is the one where most of the people found themselves, and they said that it was changed their life in so many ways to be able to talk with other people who had experienced similar situations or were living similarly to how they were. Next slide, please. So one of the things I did from all of this work was adapt the shifting perspectives model of chronic illness to TPN dependency. And this model really talks about when illness is in the foreground and features when wellness is in the foreground. So I kind of changed that to when TPN is in the foreground and when TPN can be in the background. And some of the factors that fell under this on the left, this would normally be the purple and blue circles would be changing, if you can envision that. And so when TPN is in the foreground or the illness in the foreground, there was a recognition that the TPN was really burdensome. And a lot of times this came with complications associated with the line. There was an element of feeling confined by the infusion schedule where individuals reported having to cut evenings short or having to race home to hook up. And there was no sense that this could be adjusted. And in many ways, it was like they had to fit their life around the TPN schedule as opposed to a flexible schedule when wellness would be in the foreground, where people learn to adjust the schedule to fit the lifestyle that they wish to have. Some of the other features were just the feeling of having strength and stamina. Obviously, was a wellness in the foreground, where physical weakness was really associated with illness. Self-pity versus positive attitude, social isolation versus social interaction. And this whole concept Swapna spoke about, I heard repeatedly in my work, that in the period of time, sometimes before parenteral nutrition, and even sometimes in the process of trying to weaning or reduce or discontinue, there's a need to focus on eating and drinking all day long. And that sometimes does induce pain, further GI symptoms, a lot of anxiety, and sometimes that eating and drinking led to weight loss and feeling really poorly. And so with parenteral nutrition in the background, that provided a nutritional safety net, not just a lifeline, which you hear our patients and clients talk about all the time, but a true nutritional safety net, giving comfort and safety and security, knowing that the nutritional and fluid needs were being met by the parenteral nutrition solution. And when that was in place, they learned to eat for health and comfort and pleasure, and could participate in social situations and take small bites of food and enjoy that, as opposed to eating to live or eating to survive. And the arrows just tell us that this is shifting, that this is not a static thing, that people move into these different fields or different scenarios. And I think one of the factors that moves it is line infection and complications and rehospitalizations. Next slide, please. So with the knowledge that there is a need to talk about quality of life in patient and client encounters, I have heard and found in the work I've done that the HPN consumers or patients find their medical visits focus primarily on medical and disease aspects of care. And they call it basically parenteral nutrition tune-ups. But the preference is for a more holistic approach with emotional support in addition to medical exam and nutritional assessment. And on the other hand, the clinicians working in this space really do desire support for assessing quality of life and psychosocial issues and are not always trained to do this. And so this collaboration with mental health expertise and providers, as we're hearing in these sessions, is really valuable. Next slide. And so what I did was come up with a questionnaire that's been validated, and it is now used as a conversation starter. This is the Home Parenteral Nutrition Patient-Reported Outcome Questionnaire. And so this tool is meant to not quantify with a number quality of life, but it's to allow the individual to self-assess areas that they want to raise when they're with a clinician during an encounter of any kind. And the features on this form, I won't read them, really relate to some of the very specific situations of living with short bowel syndrome, intestinal failure, and with having to use parenteral nutrition. So it's a valuable tool, and we use this in our patient office visits, and it does change the conversation a little bit more to the areas that are really important to the patient. Thank you.
Thank you so much, Dr. Winkler. And now we're going to hear from Ashley Roberge.
Hi, yes, thank you so much, Dr. Kim. My name is Ashley Roberge. I'm a licensed clinical social worker at Boston Children's Hospital, and I'm going to talk about caregiver fatigue, supporting caregivers of short bowel syndrome patients. So next slide, please. So essentially caregiver fatigue, I would say, is kind of expands upon the wear and tear hypothesis that Dr. Allen was talking about. It's, when thinking about caregivers of short bowel syndrome patients, we see that they wear a lot of different hats. They're nurses, they're advocates, they're case managers, and they're still mothers and fathers who are trying to balance a million other things in the households. So of course, with all of this, they're going to be physically exhausted. But something that can kind of be forgotten is the mental exhaustion that comes with having to balance all of these things in one day. So while we think about the mental health of our short bowel syndrome patients, especially as they get older, we can't forget to think about their caregivers and their mental health. Next slide, please. So signs of caregiver fatigue can definitely be on a spectrum. It impacts their mental health in various ways, such as anxiety, depression, high stress, lack of sleep, and even PTSD from hospitalizations. And some signs of these impacts that can come out that you may observe as a mental health provider is frequent non-urgent phone calls, emails, and pages to team members, requiring continuous reassurance about medical plans, the patient's safety and health, increased frustration directed towards medical teams, providers, or social workers, particularly when plans are changed or unexpected admissions occur. We can see this a lot during clinic visits. Attempts at home medical decision-making as a way to try and decrease symptoms and prevent hospitalizations, and difficulty returning for admissions or outpatient appointments, especially after long-term hospitalizations. Next slide. So I figured a great way to highlight this is through a case vignette and a very real experience that a family can go through as well as a team can go through. So I have baby boy G here. He's an 11-month-old patient with short bowel syndrome. He's dependent on PN 7 days a week and receives formula through his G tube. He was hospitalized for the first 4 months of his life, but he's been home for the past 7 with 2 short admissions. Since being home, mother contacts clinic staff via email and phone calls between 5 to 7 times a week. Patient's mother also pages the emergency overnight pager at least every other week for non-urgent clinic questions. So this means questions about maybe supplies or questions that should be able to be managed during the day that wouldn't require some type of immediate triage. Mother reviews G's labs via his patient portal and questions why the team doesn't call about results that she deems concerning, despite clinical staff confirming they're within safe parameters. Mother will also deem certain antibiotics as the reason for G's presenting symptoms and decides to stray from the pre-established medical plan of care without consulting the team. Next slide, please. So just a disclaimer, regardless of the level of appropriateness of this mother's concerns, her concerns present as coming from a place of love, compassion, and advocacy for G. They're not coming from a place of harm or at any point has it reached any type of child protection concern. This is really just coming from a place of anxiety and caregiver fatigue. And we can see that because I pinpointed in green, I don't know if you can see that on the screen, the pieces of caregiver fatigue that you can hear throughout the vignette. So for example, we're starting off where she's coming off of 4 months of his life being admitted to a hospital. That in itself is absolutely emotionally draining. You are not getting any sleep because you're having nurses and team members constantly checking on your little one. You're trying to learn as much about short bowel syndrome as a doctor who spent all their time in medical school learning about it. And you're also trying to manage everyday life, whether that's work or monitoring other children at home. So that can set anybody up for some type of mental exhaustion. But then coming home, we see that the anxiety about what it's like being home intensifies by emails and phone calls between 5 to 7 times a week. The constant paging of the overnight pager for non-urgent questions, questioning the team's decision on whether or not lab levels are safe, also deciding to stray away from any type of plan of care as a way to try and help this baby avoid an ED visit, which can also be stressful. Returning to an ED, especially during the pandemic, is something all parents are trying to avoid right now. So through this vignette, I hope you're able to see how there are a lot of different signs of caregiver fatigue that you may hear and see, whether you're a team member within the clinic or even a community provider. Next slide. So now that we can see how to identify what caregiver fatigue looks like, we want to see how we can help them. And the ways we can help them certainly depends on the level of mental health impact that they're experiencing. So it's good to start with engaging in reflection around the patient's medical journey with the caregiver, the multiple roles they're playing, and normalizing the caregiver fatigue as a common phenomenon. This acknowledgement of caregiver fatigue is not meant to penalize them or make them feel bad for the actions that they're engaging in. It's meant to acknowledge the fact that they have a lot on their plate, and we're here to help support them. So something that is always passed around is engaging in self-care. And a lot of parents laugh at me when I say this because they're like, yeah, right. Okay, how do I have any time for something like that? I just reviewed with you all of the things that I try to do in one day. How can you ask me to do that? But this doesn't have to be something as huge as taking a vacation. This could be something as small as taking a shower, making your favorite meal, utilizing breathing exercises, recognizing that engaging in self-care doesn't have to be this huge task, but maybe something small that they used to have prior to taking care of somebody that is very medically complex. We also want to access community therapy. So empowering caregivers to use insurance and internet tools such as psychologytoday.com to search for a therapist. And this can be a very daunting task, especially during the pandemic. We're seeing it's really hard to find a therapist right now. But as a social worker and a team member, it could be really helpful to help guide caregivers by showing them how they can reach out to their insurance and utilize free tools to access therapists that are available in their area and who already take their insurance. And when you're looking through these therapists, you want to consider therapists who actively work with anxiety, ones that work with medical coping, and also long-term illnesses. Another great thing to do is exploring support groups and national short bowel syndrome organizations like Swapna was saying. It definitely creates a community for caregivers who can relate and share experiences with others caring for children with SBS, because it is such a unique illness, and not everyone can understand what it's like taking care of a kiddo with short bowel syndrome. Next slide. So how do we enhance support? I thought this slide was especially helpful if you're not coming from a hospital environment. So how do we as just general mental health providers learn more about short bowel syndrome and ways to support them? Well, definitely educate yourself on the basics. There's a lot of different types of short bowel syndrome that's associated with intestinal failure, whether that's NEC or gastroschisis, ileal atresia. There's so many different things involved, and all of them can lead to different ways that the child is taken care of. So having a basic understanding is really helpful. Reading the literature on the impact of chronic illness has on family dynamics is very important. The literature is growing. It's not super big right now, but as we saw from Dr. Winkler, we're trying to build up that literature. Validating the fact that caregivers are their child's best advocate, acknowledging that they're putting in all the hard work in trying to fight for their child, and that while it's exhausting, their efforts still go unnoticed. Acknowledging the time involved in providing medical care for their child and the multiple roles that they're playing. And then finally, don't be afraid to ask questions. Ask clarifying questions, because they really are the experts in the situation. And while they're probably exhausted from talking to medical providers, it's really different when you have the opportunity to talk to a mental health provider. So not being afraid to engage in those conversations and ask questions can really help guide your practice. And that's it. Thank you so much.
Great. Thank you so much, Ashley. And now we're going to hear from Michele Rubin.
Hi, thank you, Joe. I actually am an advanced practice nurse. I'm a clinical nurse specialist, and my specialty is totally inflammatory bowel disease. And so I'm going to talk about the Crohn's disease patient who ends up actually with short bowel syndrome and some of the things that she goes through. Next slide. So our patient, right now, she's a 57-year-old female who was diagnosed in 1986 at the age of 18 with ileocolonic perianal Crohn's disease. Now, she's had a couple years before where she actually had the disease, had symptoms, but not severe enough, and just wrote it off as this is probably stress, because when I eat, I have symptoms. So sort of, didn't really get it looked at or diagnosed until several years later. So during that time, obviously the disease is, inflammation inside her intestine and is worsening as time goes on. She's undergone 7 bowel resections over the years. The first one was in September of 1994. So when she was diagnosed, she's been treated with some medications, but probably not optimized enough. And there were most likely strictures occurring because she's gone through multiple stricturoplasty procedures. And these are procedures that avoid resection, but they just open up the area whenever they can appropriately. Then in December of 96, she developed definitely within a short time, much worsening disease through the entire colon and fistulization in the perianal area. So she underwent a total proctocolectomy, removal of colon, rectum, and anus. And again, she had some jejunal and ileal stricturing. So therefore, she's gone through periods of multiple small bowel obstructions, where she ends up going to the emergency room, getting IV fluids, also bowel decompression for the strictures, and being sent home. She's undergone multiple small bowel dilations for these strictures in order to try and avoid resections. And her most resection, when I actually got to meet her, was in January of this year, where she had 10 more inches of small bowel removed because it was entirely strictured. So therefore, she now has 54 inches remaining. Next. So what is it about this Crohn's disease? Okay, first of all, it's a silent disease initially. One of the major goals is to get these patients diagnosed as early as we can. It's a progressive disease. Over time, inflammation starts, but then there's stricturing with remission and then flares again. And then it becomes a perforating disease where there's stricturing and with the eventual fistulas where they have perforations. Recurrence is very common. They go back and forth. They're put on medications. Some of them more recently, they're the biologics, where they can lose response. They develop antibodies against the meds. So they're moving from med to med. Compliance is an issue because there's the side effects. They hear about the lymphomas and different things. And they're like, I want to stay away from that. And then we also know that meds don't work in scar tissue. And sometimes patients are on meds for a long time and really they're not working because it's scar tissue. So she's had the 7 total resections, as you see, but the key here is really continuity of care and specialty care. She didn't have the one surgeon all the time seeing her. She was kind of going back and forth between gastroenterologists. Next slide. So what are the small bowel, short bowel syndrome issues here? As you can see, she definitely has short bowel syndrome, malabsorption syndrome with the loss of bowel that affects the bowel's ability to compensate for loss of nutrients and fluid. And the more bowel resected, the more that occurs. With the colon removed, the colon absorbs and takes the fluid out. So now we've got pretty loose, watery diarrhea stools with an ileostomy. Clinical features, I think you've heard a little bit through the other talks, but you can see all of these symptoms here and just worsen as the bowel is shorter. Treatments vary, obviously, depending upon the severity and the type of resection. Treatments of Crohn's, as I said, sometimes they stop the treatments, insurance won't pay for it, or fear of side effects, and the patient will just stop it, not tell their provider. Anti-diarrheal meds, this also progresses over time, and they end up advancing to having to go on narcotic type anti-diarrheal meds. They get the heartburn, so they're on the PPIs, hydration, nutrition, which you know about. She was always going and getting IV fluids because always dehydrating, high losses through her stoma. And she was into the enteral nutrition. She did not get to the parental nutrition yet, but obviously after we saw her, we were going to start and really get a plan moving forward. And then there's the trophic meds, which are also, we're going to plan to consider. And they promote mucosal growth and blood flow and to stop these gastric acid secretions. But again, some of those meds are expensive, insurance don't cover them, and not all of them are FDA approved. Next. So what I also thought was interesting is she would write down comments, and these are all the comments. And particularly I thought were important is she felt the providers just needed to take more time with me and listen to me, not just, talk, and then leave. Also, she felt they do not get me. They're nice and everything, but they don't get me. And then she'll say, I didn't do enough to take care of myself. Maybe I needed to be more proactive. I didn't help. I stopped my meds. I should have sought out more specialty people. And then fearful and so peed off about her health. The ileostomy, wow, that was really a blow to her. Brought really poop out of my stomach. This was embarrassing to her. So all the issues that go through that, having to get up in the middle of the night to empty, interrupted sleep, no energy the next day, constantly thirsty, drinking more, and that's a vicious cycle. It goes right through me. And I'm so worried about not being able to eat. And if I have to live on parental nutrition, I mean, some people say they don't get off it. And I don't want to hear the word short bowel syndrome. And this is what, you know, I mentioned, we talked about in our visit, and she started crying and getting anxious. She says, if I say it, it makes it true. Next slide. And then here again, living the dream. Oh my God, this is really my life. I feel like a burden to my family and friends. But despite all of this, then she, you know, there was moments she was turning around and saying, I may be down, but I am not out of this life. I'm going to turn this around. And she was on Facebook sites, and they were like, there was a lot of drama she felt on the sites. And she was like, I can't take the drama. So she sought out groups that she actually could develop a relationship with, and just found somebody more like her. But her husband said she's a great girl. She gets on with it, puts her good girl, big girl pants on. And then I thought a really good statement that actually we try and really promote with Crohn's is, I am better than this, and this disease does not define who I am. And so next slide. Resilience, that was the key that I think she found through all of it. And I'm just going to touch on this because I know we've talked about it, but the depression, anxiety comes from the disease state symptoms, having the ileostomy, feeling like a burden, and food and eating, that's a pleasure. We socialize with it. And now that's diminished, and they're eating the same foods and needing fluids. And that just kind of totally just diminishes that feeling of pleasure. PTSD, definitely an issue, going to the ER, going through IVs and procedures, even going there when she's in obstructive and sitting there during an excessive amount of time, but it's in pain and feeling that loss of control and not feeling heard. Denial, she felt, I'm fine. I do not need help. She says, I would do that sometimes just to deny all of this, stopping the medications, not telling her provider, thinking, I don't really need this. I'm not seeing a difference in it. And again, if I say I have short bowel syndrome, it's going to make it real. So the bottom line is, just ask about mental health at every visit. Just ask. That's my mantra. It is common with this condition, and they need to understand that, and to let them know they are not crazy. They did not cause this. Next slide. So I asked her, what are some things that she felt was important from her gastroenterologist and the GI nutritionist that we set up with her? Show empathy, be a good listener, and ask patient what they understood if you said, sort of that teach back method. Shared decision-making, very key. The partner needs to be involved in the treatment plan. And obviously, she said, finding that specialized care in short bowel syndrome and Crohn's disease management. And if you don't feel like things, ask for a second opinion, seek out that center. Ostomy nurse, super important when you have an ileostomy to train, and you know, just find someone that's like you. And again, the Facebook, finding the right one. Dietitian, nutritionist, I think that goes without saying, extremely helpful for helping them find food choices and assessing their nutritional needs. Next slide. Psychiatrists, behavioral referrals. Well, I think you've heard a lot about that so far on this discussion. I got her hooked up with a GI psychologist who really talked to her about that brain gut therapy and issue with short bowel syndrome, and also Crohn's disease as well. They prescribe medication, but the key is to find them a list of therapists and services that are locally, not just at our major center, but be able to hook them up locally as well. Telehealth visits, extremely important. She lives quite a ways away from our center, but also hooking up with a dietitian, the psychologist, et cetera. The Crohn's and Colitis Foundation, extremely important for our Crohn's patient. They have protected chat lines, which I think is really important, so misinformation does not get out there, it gets corrected. Again, the short bowel syndrome Facebook site, there's a lot of helpful things there. But what was really key, develop a trusting, supportive patient-provider relationship. That is so important. And building that interdisciplinary team, as you heard Swapna talk about. Next slide. And here is a list. I'm just showing you what that professional team can all entail. And as you see in the diagram, that patient is the center because that is the primary focus of all of us providers. Next slide. Telehealth, absolutely needed in this. It connects patients to specialty resources. We can screen patients before their visit already to get information. It's a tool even for community of providers to get a team created and maybe even, several providers on a visit, routine care visits with the team, access to care for urgent visits if there's something urgent and we need to talk to them and they can't get up here right away. Educational talking with them on telehealth. Just do an educational session and check in to see how patient is doing. I think that is extremely important so they don't get lost. They need to have scheduled follow-up and check-in. Next slide. And here's a list of resources, not going to go over them. Thank you very much.
Thank you so much, Michele. And thank you all for being a part of this program. Unfortunately, we don't have time for questions today. However, we are going to be coming back for part 3 next month. So we want to really invite you and ask you to consider your questions, create a list, send them to us ahead of time. We really do look forward to speaking with not only this group of faculty, but also additional faculty. And as I said at the very beginning, if you happen to miss part 1, please be sure to visit the AKHCME website for the part 1 recording. Part 2 will also be recorded and put on the AKH website. So with that, thank you so much for being here and for being a part of this program. And this now concludes the program.